Okay, so I think it's 1 o'clock, and we'll make a start. So there's a lot of things going on at ESCRS. So welcome to the lunchtime Ziemer Symposium. The title of the symposium is the Ziemer Multiverse, and the idea is show you a whole array of surgery and things that you can do with the Ziemer femtosecond laser as well. So it will show you the true versatility of the system itself. So we've got a lot of speakers. We're going to get through as much stuff and cover so many different topics as well. So without further ado, I'm going to invite my good friend Badr Khayat, who's going to be talking about who cares, we care. Thank you, Badr.
So, good afternoon, everyone. I'm very happy to kick off this symposium with a new innovation from Ziemer. I will start with this screen where we can see every possible application that can be done with the femtosecond laser in an eye. But this was not enough for Ziemer, and we have a new module that is now capable of preparing ring segment or allogenic ring segments as well as tunnels. For those who doesn't know CAIRS, CAIRS is basically allogenic ring segments that are made from corneal tissue. They are biocompatible, customizable, reversible. We can treat all kinds of keratoconus from advanced or early to advanced cases, and it's more effective than the synthetic segments as we can implant those segments more superficial with a smaller optical zone, and we can implant also thicker segments. So the preparation of the segments, as per the original technique from Susan Jacob, she introduced this double trephine, where the segment is then cut manually and even in a customized way, tapered way to treat a special kind of form of keratoconus. I introduced the all femto CAIRS in the preparation of the segments, where we started doing that with the femtosecond laser, but in 2 steps. So basically, we cut a lamella and then a smaller side cut, and thus we had this 360 ring segments, and then it's cut to the arc length that we wanted. I'm very happy to introduce the new ring segment module that is now on the platform, or the Ziemer platform, which includes the ring segment module that will be capable to cut ring segments, as well as the tunnel modules. So I'll start with the ring segment module. This is a video of one of the surgeries. Here we can see that we can adjust the optical zone of the segments. We can cut 2 segments independently. We can adjust the width of the segment as well as the thickness, and we can go as deep as 800 microns. Again, we can adjust every single segment independently. We can cut symmetric or asymmetric, tapered from one side or both sides, and we have the full ability to adjust or to reform the segment according to the shape that we want, whether thicker from both sides, thinner from the middle, tapered from one side, thicker from one side, and thinner from the other side. The other advantage also here, we can scale our cut. That means that we can cut our segments a little bit peripherally in order to have more place to get maybe even more segments from a single cornea. The surgery, we have, of course, to remove the epithelium. We duct the laser. And this is here another great advantage. Here we have an OCT. The OCT enables us to see the corneal tissue, but also we can see the depth of the cut that we have. We know for CAIRS segments, we use mainly corneas that are not eligible for endothelial cells, keratoplasties. So mostly we have thicker corneas or edematous corneas. And this is the advantage that when we do an OCT, we can adjust the thickness of the segment according to the corneal thickness that we have. And of course, we can also rotate the segment to adjust the position of it. This is the cornea after cutting the segment. We can see in the intraoperative OCT how clean and the cut is, and we can see here the difference in the tapered segment, where on the right side it's a bit thicker, and in the left side it's a bit thinner. And to prepare or to get the segment, basically you just grab the segment and peel it off. So it's just like a LASIK flap. It's just as easy as it looks. Again, the second segment, this is, if you see the ring, this is a case where we had also done combined CAIRS with Baumann-Leyer transplantation. So the tunnel module, again, we can cut two tunnels independently from the width, from the thickness as well. We can choose the depth of the segment of the tunnel and the inner, the outer diameter, as well as the arc length. Not only that, one of the huge advantages of the platform, of the Ziemer platform, that it enables us to cut two incisions from both sides, which is very important in case, for example, if you have a longer segment for manipulation of the segment from the other side. A new advantage that we have here is that not we only can cut two incisions, but we also can enlarge the end of the incisions, which is also very important in CAIRS, because for those who does CAIRS, the very difficult part of the surgery is just to get the segment inside the tunnel. And having larger incision, it makes it very easy to get the segment inside the tunnel. So this is the tunnel creation of the patient after ducking. Again, very huge advantage having a intraoperative OCT. In this case, we have a Baumann-Leyer. It's also very important, especially for cases where we have previous flaps, for example, to know exactly where are you cutting. And another great advantage for Ziemer platform, once you duck, you do not get stuck. So you still have the option of recenter your cut according to whether the optical to the center of the pupil or whatever you want to do. Another new advantage here that we have a circular OCT, which enables us to have an OCT all around the tunnel that we're making. And this is also very important, especially in cases where we have thin corneas, enable not to perforate, for example, the cornea while creating the tunnels. The surgery, again, we see here the large incisions from both sides. Very easy to open the incisions. And we can see here how easy it is to implant the segment. This is a bit dehydrated segment, the jerky technique as prescribed from Shady. Once the segment is inside, actually here the segment is wider than the tunnel, but we still see how easy it is. Once the segment is inside the tunnel, it's very easy just to push it all through the tunnel and position it to the right position that we want. Here I'm using the marking that I made in the middle of the segment, and with the digital marking system for Callisto, just adjust the position of the segment to the axis that I have planned. Some very quick clinical outcomes for some patients. This is a very, I would say, standard keratoconus patients where we see on the right side very regular cornea of the CAIRS. This is another case where we have very thin cornea. We have combined CAIRS with Baumann-Leyer transplantation. We see on the left upper side the topography after the surgery. And this is not, we are not showing only the best cases. This very similar patient in both eyes have almost the same results. So for some extreme cases, this is a case where a patient had a PRK, refractive, and then he had some irregularity in the cornea, then he had a topo-guided PRK afterwards, still was not really happy, has a very good vision, but he has some ghosting. So those cases actually are not the best for CAIRS, actually. They're not standard case for CAIRS, but however, we performed CAIRS in this case, and we have afterward a very regular cornea. How we did that? We have implanted a very thin CAIRS segment, which is only 200 microns. And with this 200 microns, we were able to flatten the cornea just to diopters and the keratometry. And we see on the right upper side, we have this coupling effect, flattening in the inferior part and steepening in the upper part, which gave us the central very regular cornea. This is another very extreme case, a patient with 8.5 diopters of astigmatism, where we implanted very short segments at the steep axis, as we see in the photo, and we got this very regular cornea. And we reduced the astigmatism from 8.5 to 1 diopters. So we reduced the astigmatism of 7.5 with a very minimal invasive surgery that does not take more than 5 minutes. So I'll come to my conclusion. We have a new state-of-the-art ring segment and tunnel module with very advanced capabilities. We can fully customize our segments. 2 segments independently can be cut symmetrically or tapered with OCT guided thickness control. We have versatile tunnels, again 2 independent tunnels that can be cut in different depths and adjustable start and end incisions, and those are compatible not only for CAIRS or CAIRS with CAIRS Natural, CTAC or other segments, but also for PMA rings. And we have intraoperative OCT circular scans that enables us to fully or full-length visualization of the cuts that makes our cuts very safe, especially in thinner corneas. So with this new modules, we have actually the fully customization of the segments and the tunnels that combining all Femto CAIRS features into a single versatile laser platform. Thank you very much.
Come and take a seat. So I'll invite Theo up to the podium. So, I'll just ask you a quick question. You showed it beautifully, 2 segments taken off from the cornea. How many segments can you cut from a donor cornea, typically? I know it'll vary on basically the individual patient, but...
Basically, you can actually cut as much as you can. The thing is, in Germany where I work, we cannot use a single cornea for more than one patient, so we only use it for single patient. But theoretically, you can cut 5, 6, 7 segments even from a single donor cornea.
Okay, great. All right, thank you, Bada. Okay. So the question is there any effect on the docking if you cut more than 2 segments?
Yes, the trick here is not to remove the segments. So keep all the segments, cut all of the segments first, and then remove them. Because if you
so don't keep on redocking them.
The docking will not be cut.
You can keep on cutting them across, and then basically separate them from there as well. Okay. If you have any questions, and if you go to the app, you can basically put the questions in the app, and then we'll get them over here on the iPad as well, and then we can go through them as well. Okay. So the next speaker is going to be Professor Theo Seiler from Switzerland, and he's going to be talking about the power of OCT. Thank you, Theo.
Yeah, thank you very much, Dot, for the introduction. We've already seen about the power of OCT in the presentation before. However, I would like to also point out some advantages of that intraoperative OCT. So this was a book chapter which I've written 5 years ago. However, one thing is missing. What did I forget? Of course, the OCT and the separate femtosecond lasers. And I would like to jump in with such a case. You see a typical hyperopic astigmatism patient demanding LASIK, and I did the suction of the eye, and it wasn't perfectly centered. Hyperopic astigmatism is always a bit more tricky to do the suction. I already increased the anterior and posterior diameter of the flap. And you can see here small slight bubbles, and you think, okay, that should work. However, you're not really sure, because there's also that pseudo-applanation where there's a tear meniscus, and if you have a look at that ablation profile, this part here has to be a good flap because you're ablating there a lot of tissue. So we had the power of OCT, and we've seen this picture. And you can clearly see that this flap has just, although it looks good, it's not perfectly applanated, and if you lift that flap, you will definitely induce irregular astigmatism and an unhappy patient. However, just to point out the pseudo-applanation, which you can prevent with performing in each case an intraoperative OCT, you can prevent patients from an unsatisfying result. Why anyway do we want to prevent 2D flaps, like in this case here with the recentration? Because 2D flaps, they always have the risk for epithelial ingrowth at touch-ups. We all know this, and that's the reason why you should not use 2D flaps. Especially all those patients, they come in 30 years later again for cataract surgery, want to become spectacle independent again. And if you need to do a retreatment, stick on the 3D flaps with a good side cut, as you can see here. Where else do we need the OCT for? Think about thick epithelium prior to surgery, where you want to minimize the percentage tissue altered in order to prevent any ectasia. Here you can see an epithelial thickness of 70 microns. And again here, what you can see here, is the intraoperative OCT, which absolutely helps me in this case. You can see I do the suction, I decrease the flap diameter. Since I already saw, I reorientate the flap, what you can perfectly do, the lateral decentration, recentration, and then afterwards, the adjustment of the thickness of the flap, because you want to save as much tissue as possible. And this is something you can be sure, although he has a preoperative thick epithelium, we can go down to 90 microns, and I have a good feeling, and the patient had a good result afterwards. I don't want to show this again. Or another nice case, 40-year-old patient, which was at my father 22 years ago, had a microkeratome LASIK at that time. You can see the typical epithelia difference, the typical oblate cornea, and now the correction is +1, and she demands monovision because she's getting in the presbyopic or in the presbyopic age. So if we have a look at the OCT, we can see, okay, was a 150 microns flap, but she has a good residual stroma thickness. The flap was small, I don't want to do a touch-up in this case, so what can we do? We can do a deeper flap. And this is what you can see here in this video. You can see here the flap, the initial flap, you measure the initial flap, you just go 30 microns deeper than this. And you can generate a nice flap with a big optical zone in order to perform that hyperopic treatment. And here you see the result. We got the deeper flap with 190 microns, so 30 microns deeper than we initially had the case. Pre-op curvature, post-op curvature, you see that nice steepening of the cornea and an unhappy patient later on. And of course the monovision was achieved. However, there are also other applications where you can use it, not only for refractive purpose, but also for therapeutic purpose, like in this deep corneal scar, which you see here. It's a typical case for a DULC, and we all know that DULC is a very challenging procedure. It's unclear how long it will take. Sometimes it works with a big bubble, sometimes it doesn't work with a big bubble. You do have to do a manual separation. So can the OCT help there also? And yes, it can with a big bubble generation. This was a manuscript published by Jordan and my father 5-6 years ago, where they introduced that channel, that predestimate channel, in order to facilitate the big bubble generation. And this is something I would like to show you as well with the intraoperative OCT. You see here the tunnel, you see the OCTs, just enlarge it here. You see that scar, you just measure the thickness up here, you go 30 to 50 microns anterior to Descemet's membrane, and you do a perfectly adjusted predestimate tunnel. You know where you are. We know that the predestimate tunnel is facilitating the big bubble generation, and afterwards the tunnel is generated in this case. How does it look afterwards when you do such a DULC? This is here, you remove the surface lamella. Here you can see the tunnel, you still see some cavitation gas. I'll just mark the tunnel, decrease the pressure, get in that tunnel, push it a bit forward, that it's going to be tight. You see here already Descemet's membrane, the folds that you really just anterior of Descemet's membrane, et voila, you have a nice big bubble. However, it could also be that it's just the nice cases which we show. A co-worker of mine analyzed in the past 3 years all our Femto DULC results. We had 52 Femto DULC attempts with 42 big bubbles, so we are in the range of 80% success rate with the big bubbles. Of course, you might have some during the preparation also there you can have some problem, but we're in the range of 80% success rate in DULC, which what I had so far with manual DULC was definitely less than the 80%, but it depends also on the surgeon. So let me conclude. Pseudoapplanation with a non-3D side cuts can be avoided using the intraoperative OCT. Increased safety, especially for large abrasion profiles like hyperopic ablations, and potential touch-up in the later course. Intraoperative OCT allows on-stage surgery in difficult and challenging surgeries, like when they already have a flap, other complicated cases. We can do an excellent lateral reorientation, flap diameter, thickness, all that we can adjust on stage. Secondary deeper flaps are possible with minimal risk for slivers. Intraoperative OCT is also increasing the safety, standardizing and facilitating Femto DULC, which we're able to show and is going to be published in the next month. And for me, I'm performing an OCT in every single patient when I'm working with the Set 8. Thank you, Ziemer, for this powerful tool. Thank you very much.
Thank you, Theo. So, I mean, you show some very nice pictures of the OCT in many cases as well. And you feel that, I mean, that's, I mean, out of all the laser systems, it's probably Ziemer's the only one with the OCT itself. So it allows you to do on-the-fly manipulation to actually know what's basically going on. Do you think it changes your decision-making on every case, or? Yeah.
So I think sometimes even the most experienced surgeon, if you do an applanation and you have that pseudo-applanation, for example, in hyperopic treatments or high astigmatism, if you have a large optical zone, it's just mandatory because, you know, it costs you 2 seconds more or 3 seconds more, but maybe you can save a patient from irregular astigmatism. So it's definitely something every surgeon in our clinics has to do it because it's really a gain in safety. And I think with the DALK, it's obvious that if you have a nice predestimate tunnel, that it's just a better solution, and I would recommend it for every patient.
Yeah, no, I completely agree. I think the OCT is the real game changer for the DALK actually as well. Okay, so our next speaker is Professor Leccisotti from Italy. He's going to be talking about, we're transitioning now to refractive surgery, so we're going from LASIK to clear. Thank you.
Thank you everyone for being here. I'm just going to tell you why you should integrate lenticular extraction by clear in your already successful LASIK practice. These are our numbers. We do 0% surface ablation. It's mostly Femto LASIK, and we are gradually increasing the number of clear performed. Why Femto LASIK is our main dish? It's because it's supported with eye tracking. It's at early visual recovery, the learning curve is short, it's forgiving, and the retreatment are easy, less suction time. But we can choose several options provided by the Ziemer software. So you can have Crystal LASIK or Z LASIK Z, depending on how you want to customize your flap. We have studied in the past several complex cases treated by femtosecond LASIK, such as hyperopia, post-radial keratotomy, or on previous PRK. You see in this picture why we like the Ziemer suction system and a planating glass that create very large flaps, as in this case it's more than 10 millimeters. And this is how you can do touch up on previous radial keratotomy by using normal flap and then paying some attention while you separate the flap entering between the cuts. And this is a good case of femtolasic after penetrating keratoplastic. You see the flap is larger than the graft. Pre-op, we have here a very large cylinder, and this is the post-op. You see the cylinder is become reasonable and treatable with simple glasses, and you see on OCT section that the flap edge is over the grafted area and a very smooth, very regular interface. The treatment of eyes with scars is also feasible, and the laser beam passes through scars provided they are not too dense. This is an old trauma with a pencil with still remnants of graphite, and you see on the right the yellow arrow is pointing to residual graphite on the flap, but which is perfect and complete. But then why to integrate lenticular extraction in this practice? Because it has some peculiar advantages. It needs no fixation. It saves tissue. If the cap is really contributing to strength, it's inducing less dry eye. It's resistant to trauma. It can be used in people with implantable defibrillators. And it's possible, even if this is off-label, in post-herpetic scars, because it has no ultraviolets, very small epithelial disruption. This is how clear creates a larger optical zone versus femto LASIK. This is the same program optical zone, but clear as a result to be larger. Lenticle dissection, you see here we are using a regular instrument, a globe holder, and then a rhinestone spatula, which is provided with a gentle olive tip point so that the anterior interface is dissected. Now we are in the posterior interface, and the lenticle is removed very easily, and it's picked up with a forceps. Clear can be done on high errors. Here we see very large cylinders on a regular map, and we see the post-op, the 6 cylinder has become 0.41, and in the left eye 0.06, so very good results. And it can be done on scars. You see that the beam has separated well the lenticle. We have pre and post. And on low myopia, the lenticle doesn't tear. It comes out perfectly. And also in uncooperative patients who are unable to fixate the red light, you can do such good cases. You see the red eye. Right eye was performed by Femto LASIK, but the patient was completely unable to fixate the red light. So we did the left eye with lenticle extraction. You see the results are even better. And so we can pick up the best of both procedures. Thank you very much.
Great. So remaining on the same theme of lenticle extraction, our next speaker is Dr. Koo from Korea. So he's going to be talking about something new called the Ziemer FlowSuite. Thank you, Dr. Koo.
Good afternoon, everyone. My name is Hyung from Nunemis Eye Center in Seoul, Korea. I'll be presenting Ziemer FlowSuite, which represents the next step in the evolution of CAIRS. Keratorefractive lenticle extraction is a single-step all-femto laser surgery without flap. At this time, there are 5 different femtosecond laser platforms are being utilized. Clear surgery is the CAIRS using Ziemer Z8, which acquired CE mark in 2020, the second platform on the market. Our Nunemis Eye Center has all 5 femto laser platforms, and it became the first clinic worldwide to implement FlowSuite upgrade. And my presentation will cover 2 topics. First, I will introduce the Ziemer FlowSuite and share how it works, and we will explore the benefits of clear upgrade integrated with FlowSuite. The next generation clear surgery is called Clear Supra, which is supported by major upgrades, including optimized scan patterns for homogeneous gas production and separation, and faster laser cut, optimized vacuum pressure for gentle docking, and automated centration and cyclotogen compensation, and FlowSuite for seamless data transfer between Galilei G4 and Z8 platforms. This is the key point in today's presentation. Ziemer FlowSuite software upgrade provides seamless device connectivity between Ziemer's diagnostic and surgical devices through a centralized server. The features include centralized data management and streamlined entire process from patient registration to post-operative care. An innovative user interface that simplifies the complex procedure and advanced surgical planning. The integration of Ziemer FlowSuite and clear surgery truly provides advanced and automated surgical planning. It obtains preoperative data from Galilei G4 and performs fully automated centration and cyclotogen compensation. This slide shows the data collection procedure through FlowSuite program. We begin with patient registration, followed by patient selection, and preoperative examination using Galilei G4 generates its data, And surgeon can check the examination results and selects the highest quality examination. And the system automatically completes and transmits it to the server. Clear surgery with FlowSuite ensures fully automated data transfer capability. It directly obtains preoperative data in the surgical room through network system, so we don't have to use USB or other storage devices. The upper iris image was acquired using Galilei G4 prior to surgery, and lower image was captured immediately after docking process, and Z8 compares two images automatically and confirms the precise matching between the images, iris images, and performs the cyclotogen compensation and centration recognition and adjustment. So there is no need for manual modification. You can see real-time automatic modification screen video, and on the Z8 touch screen, you can confirm the precise iris matching, and you can see the green dot, and you can proceed the procedure. And you can, the cyclotogen compensation and centration was, okay. You can confirm the cyclotogen compensation and centration, and then finally, OCT image can show the position of lenticule and side cut. And then you can press this button to start the laser application. Before clear supra, we should mark the horizontal axis of the cornea and visual axis of the patients at the slit lamp prior to surgery, and you should drag the lenticle center to align to intended position and rotate the lenticle axis to align with the preoperative mark. But now there is no need for preoperative marking and manual modification after docking. So it allows for faster workflow, less than 5 seconds for automatic cyclotogen and centration checking. And here you can see lenticle dissection in clear supra. Based on my personal experience, clear supra enables the smoothest dissection without resistance among all 5 different platforms. In summary, the FlowSuite upgrade enables integration and automation, allowing procedures to be performed with enhanced precision and convenience. So in conclusion, in the era of CAIRS, achieving vision beyond 2020 demands more sophisticated surgical capabilities. Through this comprehensive upgrade that encompasses automation, customization, and integration, the Z8 Clear Supra enables next generation CAIRS surgery. Thank you for your attention.
Great, thank you, Dr. Koo. That was very exciting to see that. And just to add, so the FlowSuite will be linking the either G4 or G6 to the laser for CAIRS, but obviously later on you'll be able to use it for other procedures, for cataract surgery, and also for other transplants as well, where we link to topography to also help you if you want to do AKs as well. So our next speaker requires no really introduction. He's a well-known refractive surgeon, Professor Shady Awwad from Lebanon. He's going to be talking about CLEAR, his journey through excellence.
Thank you, John. Okay, so the title says it all, CLEAR, a journey through excellence. And I was fortunate to witness that journey step by step. And before I start the talk, I would like to summarize basically the one-year result that were really followed patient per patient and published in the Journal of Refractive Surgery. That's a QR if you like to, examine the whole paper. But I want to summarize what really CLEAR is before talking about the updates and what CLEAR offers now. But we have to remember that CLEAR is truly a very effective and safe procedure. And that's important because I keep seeing every now and then surgeries where the lenticle couldn't be found, you have suction loss, retained lenticle, but if you have really great energy, great dissection, perfect suction, we don't have to fiddle with that. And I think that's really the number one. I mean, we think about lenticle surgery as a quote-unquote minimally invasive. It's not. I think we've mastered the complications of LASIK, and we're entering a new era. And I think the number one is a safe procedure, and that's what we really find with the low energy with the Ziemer. So basically, with the demographics, with an MRSC of minus 4.11, a cylinder up to minus 3. The cap thickness at the time was 130, now we're basically going to 120, an optical zone of 6.6, and this is the sweet spot for us. The postoperative visual acuity was 20/20 or better in almost 97% of patients, with 20/16 or better in 50%. If we look at the change in CDVA, how many patients gain one line, that's a whopping 40%, and only 5% of patients lost one line. The spherical equivalence refraction is also dead on target with almost 97%, a little bit less than 7, being basically plus or minus half of a diopter. And amazing stability, much better than we really see with excimer procedure throughout the full year. Again, the attempted versus achieved is right on target. And if you look at total corneal aberrations, again, if you look a little bit induction of total aberration, that's very normal. But the spherical aberration is almost untouched, barely 0.09 of induction. There is a minimal induction of not vertical, of horizontal coma. And I'll tell you why. I usually centrate with one of my excimer laser where it has a very large stereopsis axis, which means it's not a coaxially sided. So basically, I'm right eye dominant. If I close the left eye, I see the fixation light a bit deviated that way. If I close the other eye, I see it the opposite way. So it's kind of very tricky, even with my marker. I have my marker to have a 3-line marker based on the visual axis, but it can get as good as my approximation of the light reflex is. But the point that you really can get great fixation, is a great centration, is that the vertical coma is dead on target. We didn't increase it at all. And that's not, typically not what you see. The angle alpha and kappa is mainly horizontal in physiological eyes. So that's why it's different. Why the vertical angle alpha and kappa is almost nil. So that's the reason. But I think now with the new introduction of the registration through the Galilei, this is going to be even better. Now, how about astigmatism analysis? And we get it a lot. People say, well, you're centering basically, manual centration. The astigmatism is not great. Now, of course, we're gonna soon have the automatic centration, just like you saw with the previous talk. But let's look at what we get if you do manual centration. And you see it's dead on target. 97% achieve less than plus or minus half diopter of accuracy. The achieved versus attempted versus achieved is also pretty good, very minimal under correction, which is normal. And then the 12-month analysis, we see an excellent plus or minus 5 degrees in almost 80% of patients. And that's the centroid before, and that's the centroid after. The center is almost 0.01 at 94. Now, how about the new updates? So one of the updates is actually lower suction pressure. And that's, for me, it's amazing because the patient feels much, much more comfortable. And I've never, ever lost any suction with the lower parameters. So I invite if some of you didn't even update to that, definitely that's a game changer. Patients feel much, much more comfortable. 2 is actually a new, faster interface cut. Again, that's a game changer for me for 2 reasons. One, it's super fast. It cuts down the suction time dramatically. But more importantly, it's actually much smoother dissection. The problem with me before was that the typical traditional concentric out-in was leaving some bubble in the center, and sometimes every now and then, depending on the eyes and the interaction of tissues, I used to have problems dissecting the very center, especially if I want to go to low energy. But with this, it's a no-brainer. It's always going to dissect super smooth. I'm going to give you an example of what you see on the Z8. So you start with a concentric first. And mind you, now you're gonna start seeing first the central treatment. You see it now, the incision, and then now you can see the green. It looks like a raster cut, but I'm sorry, it's not the raster cut. So it starts in the center, then outside, in, outside, right, left, right, left, right, left, all the way to get to the center. The surgical impact, again, is really remarkable. And then with technically in the center, you can see very, very smooth dissection in the center. And that's the day one retroillumination. Now, mind you, you don't get that on every single patient, but you do get very often, and that's, again, a game changer, especially if you're using low energy. This retroillumination image from a pyramidal aberrometer like Osiris. Now, how to speed up the early recovery? What I did before, and still doing it now, is developing a homogeneity score for a retroillumination image. And that homogeneity score is basically based on image analysis. So take a look at this retroillumination image from a pyramidal aberrometer. It evaluates the homogeneity, and then it gives you a number. 0.85 is almost pristine in normal physiological eye. Of course, a blank piece of paper would be 1, but normal eyes would be like 0.84, 0.85. You can see this is day one of a case of 0.77. And that's 1 week out, much better, but it's 0.82, so almost not yet to the preoperative one. So what I discovered by playing around with this parameter and playing around with parameters and checking with my H-score, seeing what really makes a difference. So basically, I noticed that the lipid layer is the most important one. I talked about it last time, but basically what I do, I really irrigate with 5 to 10 cc's, turn the patient temporally first, then turn the head back nasally. This is optional, but I take a wet wax cell, dribbling wet wax cell, just to smooth out very gently. I don't want to create any epithelial defect here. Now, this is optional. If you do the irrigation, that might be fine enough. And more importantly, shield the meibomian gland with the drape. And that's important because once you squeeze in that speculum, you're gonna get those meibomian gland flowing in. So the most important thing is not to dry out your tear film, but to homogenize it. Again, because low energy femto pulses are gonna get scattered by a haphazard lipid layer. And that was the reason why sometimes I used to see patients getting mud cracking on the first day, retroillumination, some others better, because people have different lipid and meibomian gland layers. And you can see really day one, very, very smooth interface. So what we did a one-to-one match using propensity metric score. So what we do with that, we looked at all our patients done before that procedure. We looked to our patients done after that iteration. We matched them through a machine learning algorithm that look at many parameters that we put, like age, sphere, cylinder, CCTK, lenticle, cap thickness. Of course, we give them brackets. And then the machine learning program picks a certain number, in this case 116 eyes, 58 in each category that are matched based on these categories. So this way we know we're comparing apples to apples and not apples to oranges. So basically what we found out when we looked at the H-score, that with the new KLAX, what we call the new is after homogenizing the tear surface, we saw that much better H-score on one day and 1 week. And then ultimately, they all get together, they're similar at 3 months. And of course, much better CDVA minus UDVA post-op, that to see what's the best of improvement on 1 day and on 1 week as well. So basically, much faster recovery. By 3 months, they're all the same. So again, that was, again, a game changer in my practice. So finally, as a conclusion, definitely with Clear, we can guarantee excellent and stable results. So if we are transitioning, we should not fear the transition. And 2, with new advancement that Ziemer has laid out over the past year, that definitely is showing with new metrics that we are developing. So again, Clear is truly a journey through excellence. Thank you.
Dear Shady, thank you very much for this, for those new insights into Clear. I'm looking forward to it. It's a pleasure to introduce the chair of this session, Professor Mehta from Singapore. He's going to talk about Zomics, Ziemer, Omics, and Femto Cataract.
Thank you, Joe. The slides on? Okay, so I'm going to introduce you to a new terminology, and I'll try to explain to you why I think this is important, especially when we're looking in the literature, because there can be a lot of confusion when you're seeing data in literature specifically pertaining to high-energy femtosecond lasers. Okay, all right, great. Okay, let's start with this. Okay, so most of you won't know this lady, okay? This is Joy Lin. She had the unique ability that she was able to smell from an odor of a patient with Parkinsonian disease, because her husband developed Parkinson's disease, and she was a nurse in the UK and Scotland, and she was able to smell Parkinson's disease itself, and led to a whole area of research where it was found that Parkinsonian patients actually have a sebum in their skin gland itself. And she, having been a nurse working in an old people's home, was able to pick out patients years before they got diagnosed as having Parkinson's disease just from the smell of the individual patients. But the point is that you can use biomarkers to help you define different patient populations. Now, back in Paris in 2019, I gave a talk here at a symposium about inflammation and being inflammatory and the differences between different femtosecond lasers as well. And back here, you can see the 4 current femtosecond lasers available on the market. And the big difference between the lasers is that all the lasers in red there are basically what we consider high energy, and there's only one low energy platform itself. And it's important to think about this to distinguish when we're talking about flax, where we're talking about high energy versus basically low energy flax. Now, one of the key things, of course, as you all know, is the difference in the way the lasers work between a high cavitation pulse, like in the high energy systems, compared to the Ziemer ZA, which is working in the low energy. And we published and showed categorically that there was low evidence of prostaglandin release, less pupil miosis, and less pro-inflammatory cytokines when you look at the aqueous humor of patients who've undergone low energy flax compared to high energy flax as well. Now, the thing is that things have changed, right? So now we can look at things in a much more detail than what I showed you just with simple prostaglandins. And we're in an era of what we call Omics, which is advanced analysis of aqueous or any tissue fluid itself. And this integrates the analysis of basically proteins and basically metabolites. Some of you will be familiar with genomics, and it goes all the way to transcriptomics, proteomics, which is at a protein level, but now we're talking about metabolomics, which is at a metabolite level itself. These are the end products of any basically protein that's basically broken down with a laser. So you can analyze this in way more detail than you used to basically beforehand. This is our publication, it came out in IVS basically earlier this year. You can look at it in a little bit more detail. But essentially, the study was 72 eyes. They were basically randomized into 3 groups. One received the flax system with the catalyst, so that was our high energy system that we used. One was basically with the ZA, and the third one was basically using conventional phacoemulsification. Cataract cemetery was graded as usual with LOX, and we took the aqueous fluid after the cataract surgery or before the phacoemulsification, and then we use it for proteomic and basically metabolomic analysis, and then we do a whole load of bioinformatics to basically look at the detail itself. So what do the results basically show you? So of course you get a clear segregation when you look at the PLCA DA plots over here between the control group on the left-hand side and flax. And of course we know that because with any femtosecond laser system, you're going to get induction of inflammation when you actually fire the laser itself. You get a clear segregation between the 2 groups. If you look at this in a little bit more detail, don't worry about the heat map over here on the right-hand side. You'll see from this volcano plot, you'll see some genes are upregulated and some genes are basically downregulated. And when you look at them in a little bit more detail, lo and behold, what you basically find is that the genes that are associated with the immune response to inflammation are basically upregulated in the flax basically system itself, and you basically get a downregulation of the genes that basically help you against oxidative stress, so typically PRDX2 and PRDX6 as well. But interestingly, when you actually when you look at the amino acids, again, you see a very similar trend itself, where you get dysregulation of the actual metabolites occurring at basically a cellular level. And again, it's linked to inflammation and oxidative stress between the 2 groups when you're comparing flax compared to the control group. Now, when you look at the two different laser systems, so we call them high energy flax versus what we call low energy flax over here, again, interestingly here, if we were able to show for the first time, you can get a clear separation over here in the eyes that underwent high energy compared to low energy compared to the control group on the right, on the left-hand side. This is from the protein samples, and this is basically from the amino acid samples as well on that side. And when you look at the differences between the protein response in the high energy laser system, the higher energy laser system has higher response of proteins related to immune response and metabolic and oxidative stress itself. Okay, so what it's showing you is that when you do a high energy flax system, you're getting a higher cellular response on the tissues inside the eye compared to using a low energy system. Again, when you look at the amino acids, again, there was a difference in one amino acid between the two laser system itself. And this amino acid has been shown to be endothelial protective, and there was a reduction in that amino acid in the low energy group compared to the higher energy group as well. So you lost that beneficial advantage of endothelial protection because you lost the ability to basically have this amino acid in the aqueous humor. When you look at the pathways and you look at the comparison, again, when you compare the flax group to the control group, these are plenty pathways associated with metabolism. But interestingly, when you compare high energy to low energy, all the pathways associated with higher stress were found in the high energy system compared to what we see with the low energy system. These are pathways linked to energy metabolism and also basically mitochondrial osteolysis as well. Now, because of this, there are really clear differences between high energy flax and low energy flax. And it's important to understand that if you look at these two papers over here, the systematic reviews just published recently, one in the Canadian Journal of Ophthalmology in 2025, it shows here in the conclusion of that paper that there's no comparing efficacy and safety between conventional flax and conventional phaco emulsification, that there was a slightly early better visual acuity, but no difference later on in the visual acuity result itself. But you see, when you look at the data from meta-analysis, you can call flax as a total group. They don't differentiate between high energy and low energy. But the second basic publication in JCRS, published last year, actually does a meta-analysis but differentiates it into a low energy flax versus conventional. And here, clearly you see exactly the same thing. One of these trials was our trial in Singapore, where you get less endothelial cell count because of the low energy basically flax system compared to conventional phacoemulsification. We showed previously that basically you get an increase in inflammation, which can be measured by this margin of cell. And now with this advanced analysis, it allows you to tease out the differences between basically a high energy and low energy system. So how does this basically apply clinically to your patients? Of course, if there's more oxidative stress in a high energy system compared to a low energy, this is especially in patients, important in patients who are prone to inflammation, such as diabetics or basically uveitic cells. And Zomics is something you need to think about. So it's low energy that's specific to the Ziemer system. Thank you for your attention. Okay, so last but not least, Sri is going to talk about keeping on the same thing for Femto Cataract. He's going to talk about cataract workflow. Thanks, Sri.
Thank you, John. And can I have my slides? Okay. So there is a terminology now called CAIRS for the femtocataract surgery with the Z8. It is cataract laser advanced robotic image guided surgery, because now the Z8 is connected to the imaging system, and you can get good centration from the Galilee. You can get good centration and also your toric placement accurately. So the question is, can you have a high efficiency, high volume, premium surgery? Because for most people, adapting femtocataract into the practice slows down the surgery, and the number of surgeries that you can do gets limited. But in our practice, we are able to do a high volume, high efficiency, premium surgery. So this is beneficial for both the practice and also the patient. So let's look at how we do it. I am a consultant for Carl Zeiss Meditech Biotech and speaker for Ziemer. So this is our OR setup. Of course, we have a very large OR, and we have the Z8 system. It's got a small footprint, so you can accommodate it in your OR, where the laser technician and the fellow do the procedure. Then you have a station for painting and draping, and this is the surgeon. where these beds, these are USFK beds on wheels, so it comes in, and then I have the 3D system, and I'm doing the procedure. So let's see, let's look at the advantages of the Z8 system. It's got automated edge detection and cut placements. It's got capsulotomies with very smooth edges, so the runoffs are less. It's got a liquid patient interface and a low energy concept with Professor George spoke about. It's got horizontal and vertical OCT sections and an enlarged active screen to plan your treatments. You can center the capsulotomy to the limbus or the pupil and adjust the diameter. And it has numerous lens fragmentation patterns. And this is the OR, and you can see how it works here. Once the patient comes in there, then you can see that's the overall picture of the OR, and see the surgery is going on there with the heads-up 3D system. Can we advance the slide? I'm not able to. Can you advance to the next slide, please? Yeah, this is the patient journey. So the patient is wheeled in, and once the patient is wheeled in, after anesthetic drops are put in, that is the speculum being put in, and then the suction is put on, and that's the BSS being put in for the, and then the docking is done, and the doctor fires the laser. And so it's the user interface is very easy. And once the laser is done, the patient is shifted to the next station where the eye is cleaned and draped. And then the speculum is put in and the topical anesthetic. And then the patient is shifted to the surgeon, and the surgery happens there. So I take an average of about 2.5 to 3 minutes for the surgery. So irrespective of the right or left eye, I don't change my position. The trolley is rotated, and the patient, that's the patient journey. So it takes an average about 3.5 to 4 minutes for one patient, and so we are able to do about 14 to 15 patients an hour. This is the surgeon perspective. So I'm there sitting, watching the head-ups. I do the one patient, then the next patient comes in, operates, then the left eye comes in. So that's how it goes on. It's like a conveyor system, very efficient. So this is high volume femtocataract surgery, which can be done very efficiently. Most of the lenses used are also premium IOLs. So that's how it works. And this is the bird's eye view of the OR. So you can see how it happens. So the timing is almost similar. The time taken to do the femto laser, the time taken to paint and drape, and the time taken for the phaco surgery is on an average about 3 minutes. So it's like a perfect dance. You can see there is no time wasted. And so the efficiency is very high. So this is a high volume femtocataract setup. I just wanted to share our experience with the Z8 and how you can actually have this kind of a high efficiency system where you can have a large turnover of patients and also do premium surgeries. Thank you very much for your attention.
Great, thank you, Shady. That's excellent. So, any questions from anyone on the floor? We have like 1 or 2 minutes. Everyone did a fantastic job to keep in time. Shady, I'll just ask a quick question. We can tell by the stature that wasn't you doing the laser because you're much better looking than that person. So who was doing the laser on your cases?
Basically, we have a laser tech who does the docking, and because they are trained in this and they're doing like hundreds of it, so they're very efficient at doing it.
Yeah.
But my fellow doctor who's there. He actually checks the parameters and details and
So the
fires
technician
laser.
actually does the laser itself?
They do the docking.
They do the docking,
technically, firing of the laser is done by a
doctor. Okay, okay. So it just shows you the utility of the laser system itself, that the trained technician is basically doing the laser itself. So that's excellent as well. Great. Okay. So I'd like to thank you all for attending the meeting, lunch symposium. If you have any questions, please go to the booth. Everyone from Ziemer will basically be there. They'll be happy to answer questions or any of the publications that you basically heard about or any of the technologies that you've also heard about. I want to thank all the speakers for the excellent presentations and also keeping to time, and wish you all a great conference at the ESCRS in Copenhagen. Thank you very much.